Good evening, 8th semester students. I'm Dr. Thoiba from the Department of Surgery. Going to take the class of today is Stoma and Peripheral Vascular Disease. I hope I'm audible to every one of you. So let's start first with the discussion on stoma. So what is a stoma? Stoma means an opening which is created to different parts of the body. Now it can be with the intestine to the skin, which we get in colostomy or iliotomy, or it can be with the trachea, with the skin, we call it tracheostomy. So in surgery, we'll deal with connection which is created with the GI tract, that is the colostomy, and the iliotomy, which is created between the GI tract and the skin. So how do we define a stoma? So in surgery, the ones that we are concerned with right now, stoma is an iatrogenic enterocutaneous fistula which is created. So I want to stress on the word iatrogenic. So iatrogenic means something which is created by the doctor, the treating physician, or the surgeon. So it's created between the enterocutaneous, that means entero means the intestinal tract, and the cutaneous means the skin. So stoma in GI surgery, it is the iatrogenic enterocutaneous fistula. Fistula means the connection between two epithelial surface, from the GI epithelial surface to the cutaneous epithelial surface, that is the skin. So it is the iatrogenic colocutaneous fistula created. So for the diversion of or the decompression of the bowel contents. So there are two things, one is the diversion and second is the decompression. So first let us divide this stoma into two types that we encounter in surgery, that is the colostomy and the ileostomy. When the opening is made with the colon, then we call it colostomy. When it is made with the ileum, we call it ileostomy. Rarely we used to make with jejunum, so we don't usually encounter the word jejunostomy, but inside the abdomen sometimes used to create jejunostomy, and that is a different procedure. So now we are concerned with colostomy and ileostomy. So how do we classify colostomy? First, let us divide colostomy into two. First is the decompression and the diversion, as I have said before. So decompression means when there is an obstruction in the colon, mostly in the distal colon when there is an obstruction, and the most common cause is any kind of colorectal malignancy. So if there is a colorectal malignancy, there is an obstruction in the distal colon, in the rectum there is an obstruction, then there will be obstruction, then there will be distension of the whole of the intestine. We have to make some opening in the colon so that we can divert this obstruction, and such kind of colostomy is called decompression. We are decompressing the intestine. Second is the diversion. For example, we are making an anastomosis down in the rectum, colon. This anastomosis is freshly made, newly made. We don't want to hamper this anastomosis, so we have to make a diversion. This diversion, the intestinal contents will be diverted before it reaches the anastomosis. So it's a procedure where we are protecting the anastomosis. We are protecting the anastomosis and diverting the opening, diverting the intestinal contents. So one is decompression and the other is the diversion. Then depending on the site of the colon, for example, if the stoma is open the transverse colon, then we call it as a transverse colostomy. When the colostomy is made in the descending colon, then we call it a descending colostomy. When it is made in the sigmoid, then we call it sigmoid colostomy. So depending on the part of the colon where we are creating the stoma, we have the different names like transverse colostomy, descending colostomy, or sigmoid colostomy. There is another thing called cicostomy, which is not exactly in the colon, but in the most proximal part of the colon, which is the cecum. The cecum per se is not part of the colon, but sometimes when there is an obstruction in the rectum or in the descending colon or the transverse colon, sometimes if there is a growth there, there is a blind loop obstruction, and as a result there is a distension of the whole of the proximal colon, and more so near the cecum, because there is an ileocecal valve over there, so there is a distension, and this distension is mostly in the cecum. When the cecum dilates, it is as an emergency procedure to decompress the distended and dilated cecum colon as a whole, that we create a opening in the cecum. This is called a cecostomy. So cecostomy, most of the time it is done as a decompression procedure and an emergency procedure. So we have, depending on the site or location of the colon, we have cecostomy, transverse colostomy, descending colostomy, and sigmoid colostomy. And sometimes in a terminal case of some kind of cancer, in the colorectal cancer, we have to make an end colostomy, where the stoma is made in the most terminal part or the most distal part of the colon as a end stoma. This is called end stoma because it is the end. There is nothing remaining in the distal. More distally there is nothing. So this is called the end stoma or end colostomy. So now we have we know the different types of colostomy, how it is created. We'll now discuss how it is created. So creation of a colostomy depends on it completes in 3 steps. First is we do a laparotomy. We see where is the obstruction, where is the problem. Then we'll decide which part of this colon we'll have to make the stoma. So first, if we are decided now which part of the colon we have to make the stoma, it may be descending colon, this I have mentioned before. It may be descending colon, transverse colon, ascending colon, or it may be cecum. First and foremost, what we have to do is we have to mobilize that part of the stoma. So it completes in 3 steps. One is mobilization of the colon or mobilization of the intestine. Second is creation of the trifine. Creation of the trifine. Trifine means is an opening in the skin. So first we mobilize the colon, then we create the trifine in the skin, then we do the anastomosis with the skin, and this procedure is called maturation. So it has 3 steps. One is mobilization of the colon, second is creation of the trifine, third is maturation of the stoma. So it completes in 3 steps. But before we make this stoma, we have to make sure that the site of the colostomy is perfect and it does not hamper with the normal functioning, or it works properly. That we have to make sure. So what is the next important step before you create a stoma is to locate the site or to decide which side of the abdomen should we create the stoma. So now what are the important things that we have to look before we create a stoma? First is we have to see that the stoma is not made in a place where it is most near to a bony prominence, where it is not hidden, where it is too much hidden from the person. Suppose the person is obese, he has a lot of fat, and then if you make a stoma low down, then the person will not be able to maintain his stoma, he will not be able to see the stoma. It should not lie in the belt line, because he cannot wear any clothes, any pants if it is in the belt line, so it has to be above the belt line. So we have to make sure that the stoma is far from the umbilicus. Suppose the laparotomy is made here, so it has to be far from the laparotomy wound. It has to be not that far that it has gone towards the bone. It has to be again away from the bone. It has to be visible to the person so that he can take care of it, and it should not overlie any belt line so that he can wear his clothing properly. So we have to make sure that these are the ideal sites of the stoma, of the creation of a stoma. So first we decide where the stoma should be created. We look for all the characteristics depending on the person to person. So before a stoma is made, the person should be brought to a stoma clinic or stoma OPD. There are certain OPDs or a clinic which are dedicated for this kind of patient who needs stoma. So here they are counsel regarding the creation of the stoma, and they have to be made very much clear that you can survive with a stoma, because a stoma is not a normal opening. We normally defecate through the rectum, anus, and through natural way, but a person who is about to have a stoma, he has to have some adjustment problem, because it is not normal to have an opening in the abdomen. So we have to counsel the patient that the creation of a stoma is for his own good, and these people, so many people are living with a stoma, normal life with a stoma. Of course, it will not be as normal as without a stoma, but still then a considerable amount of meaningful life can be lived with a stoma. That has to be counseled to the patient. After counseling, you make the person sit, stand, and look at his physique. Then you decide which part of the abdomen you are about to make the stoma. Then that is the side of the stoma. So you have now selected the side of the stoma. Then you explain the procedure. Then the person is sent to the OT after thorough investigations. Then we do the creation of the stoma. Now this is accomplished in 3 steps that I have already described. 3 steps, what are those? If I repeat, first is we have to select the after opening the abdomen, after laparotomy, we have to select the part of the colon which we are about to bring in the skin. So that is localization of the colon. After localization of the colon, first you do is you mobilize this colon. You mobilize it properly. It should not be in a tensely coming out from inside the abdomen to the surrounding skin. It should not be tense. It should be properly mobilized. It should be relaxed. So first you mobilize the colon. Second is what do you do? You create the trifine. That means the opening in the skin. Then third, you anastomose the bowel with the skin, which is called maturation of the stoma. So after this, we have to see that the stoma is properly made. So what are the characteristics of a properly made stoma? So in different books there are different things, but I like to simplify in 3 things. That is 3 R's. 3 R's. It should be red. It should be red. Doesn't mean that it should be bloody red, but a pinkish red. Okay, which means that there is proper blood supply of the part of the gut, part of the bowel that you have brought in the skin. That it should be red. This is one of the R. We have 3 R's. Red, rounded. It should be round. It should be in a perfect circular round thing. It should be red, rounded, and it should be raised. It should be raised from the skin. That is RAISED. It should be raised from the skin. So what are the 3 characteristics that you should be looking after a stoma is made? It should be red, rounded, and raised. So what does this mean? Red means the stoma that you are making is adequately perfused with blood. So it is red, and it should not be black or engorged red, something like that. That means you have not properly mobilized. There is tension of the colon, so blood supply is not good. So in that case, it may be very pale due to lack of blood supply. Sometimes the trifine that you have made, the opening that you have made in the anterior abdominal wall may be too small. So what happens is the part of the colon that you have brought is very, very small through a very small opening. So it is very tight. That is, it may be engorged it may be red and engorged, too red, and maybe black also sometimes, or purple sometimes. So we have to see, it must be perfect red, pinkish red. Then it should be raised from this round means the trifine that you are going to make, the opening, it should be roughly, they say it's 2 finger breadth. It should be 2 finger breadth. So 2 finger breadth. So if you are making it small, what will happen? Or if you are making it large, the size, it will not be a perfect round or circular thing. It will look like something oval, and it will not be like the normal circular looking. Then red, rounded and raised, it should be perfectly raised from the skin adequately. If there is tension, if there is no adequate mobilization of the colon, what will happen? There will be tension, so it will not be raised. It will pull towards the abdomen, inside the abdomen. So what you find is retraction. Sometimes retraction will happen. Okay, so this kind of thing may happen. Sometimes blood may be oozing out. So we have to look all those things. First is we have to see that it is red, rounded and raised. Secondly, if it is red, rounded and raised, we are fulfilling all the ideal characteristics of a stoma. That is, there is proper blood supply. There is no the size is adequate. Size of the trapine is adequate. Okay, so these are the things that you have to see. Then after creation of the stoma, we have to look for the immediate complications and the late complications. So the immediate complications are like, as I just said, retraction of the stoma. Sometimes the stoma may be bleeding profusely because you have not done adequate hemostasis. Sometimes because the tension is there, so it is retracted. Okay, so these are some of the initial complications that you find. And what about the late complications? Late complications, mostly in stoma, we find the peristomal hernias, peristomal in and around the stoma, in and around the stomal opening, there can be hernia. If you have made the opening too large, if it is not adequate, it is not the size that you mean, it is more than the size that you are supposed to make, then there is the chance of peristomal hernia. Then in some other case you have skin excoriation. Sometimes if you do not create the stoma properly raised from the skin, if it is direct in contact with the skin, so thus the gastric or the intestinal effluent or the intestinal content will irritate the skin. So you will find that there is excoriation and irritation of the skin. Then what else? There is retraction. There is chance of varices. Suppose your patient is having hepatic and other diseases. So this creation of this stoma, it is also one of the, we know there are different types, different parts in the body where there is portosystemic anastomosis. So we know that the intestine is drained by the portal vein. So the portal vein is there, and then skin is supplied by the systemic circulation. So when you make the stoma, we are creating another portosystemic anastomosis. So in some patient who has the propensity for forming varices, maybe he is having some kind of liver disease or something like that. So in those cases, you may encounter that there is varices happening in this stoma. So this is one of the late complications of the stoma. So these are the different types of colostomy. And then I forgot to mention about the other one more classification for colostomy. That is the end colostomy and the loop colostomy. Loop, where you are making a loop of the intestine. There is a proximal fist opening and the distal opening. The proximal opening from where the intestinal contents will be drained out, and most of the time the distal opening is sutured or it is capped as a mucoid fistula, because the distal opening, there will not be any intestinal content, but some mucus collection might be there. So we make it as the distal part of the distal opening is made as a mucoid fistula. Only the mucus substance which are secreted in the descending part of the intestine will be secreted. So we also have this type like end colostomy or loop colostomy, or we also have this type called the double barrel colostomy, where the two separate openings are made, and it's just like a double barrel gun. We have the double barrel stoma like this, one after another. So they are depending on the way it is made. So it can also be divided into end colostomy, loop colostomy or double barrel colostomy. And there is another one called a spectacle colostomy, which almost look like a spectacle, but those are obsolete nowadays. So it's of only historical value or theoretical value. So we have discussed about the colostomy. Now about the iliostomy. So iliostomy is nothing different from the colostomy. The only thing is the opening is now made with the ileum. So in what conditions do we make this opening in the ileum, not in the colon? Because when the large part of the colon is already destroyed, maybe because of some conditions like your Crohn's disease, ulcerative colitis, and sometimes in very theoretically it is very unlikely, but we find in tuberculosis also, in abdominal tuberculosis also, that large part of the bowel is obstructed. A large part, there are multiple strictures, so we have to make an opening in the ileum. So ileostomy is done in conditions where a large part of the colon and rectum and everything are destroyed, so we have to make in the ileum. But now in the recent literature they suggest that ileostomy is more preferable than colostomy, because they say it's easy to maintain and easy to close also. So we have one thing called closure. So if we are making as an end or permanent colostomy or ileostomy, then it's a different thing. But if we are planning to make a closure, if we are planning to make a closure of the stoma, then it is said that ileostomy is better than a colostomy, because ileostomy is easy to close than a colostomy. So that is the reason nowadays theoretically surgeons prefer ileostomy more than colostomy. But colostomy and ileostomy, ileostomy has its own set of complications. The complications, first of how will you differentiate whether a stoma is made is a colostomy or ileostomy? We all know that the terminal ileum comes on the right side of the abdomen. So when an opening is made in the right side of the abdomen, so by logic it is supposed to be a ileostomy. And when the opening is made in the left side of the abdomen, by logic it has to be a colostomy. But there is no hard and fast rule that ileostomy is supposed to be made on the right side or colostomy is supposed to be made in the left side. It depends on the condition of the patient, the decision of the surgeon. But theoretically and in practical purpose, we used to do not to confuse people or ourselves, we make this ileostomy on the right side and the colostomy on the left side. So if it is made in the middle of the, like somewhere in the middle of the abdomen, then it may be a transverse colostomy. If it is made in the left side, it is a colostomy, sigmoid, maybe descending, or maybe end colostomy. But if it is made on the right side, most of the time it is a ileostomy. Second thing to differentiate the ileostomy and colostomy is colostomy. It is more or less it is raised, no doubt, from the skin, but it is more or less flush. Meaning is it is the whole thing is just elevated, but not that long. But in case of ileostomy, it is made in the spigot configuration. Spigot means like the tape, water tape. So why is this made? Because the effluent, the contents of the intestine in the ileum is more irritant, because it has bile, it has lots of electrolytes, it has bile and all. So these are very irritant. So it will cause more irritation in the skin. So what do we do is, in the ileostomy, we make the opening a bit long or in a spigot configuration, spigot. So the contents directly goes to the stoma bag. So thereby it avoids the contact with the skin, because ileostomy contents are more irritant than the colostomy contents. Again, another thing to differentiate between the colostomy and ileostomy is the type of the fecal matter that comes out from the stoma is more or less solid for the colostomy, and it is more or less liquid and watery for ileostomy. The reason is, though the most part of the absorption of the water takes place in jejunum, the remaining part, the remaining part of the water and the solidification of the feces, it mostly happens in the colon, just next to jejunum. Most of the water is absorbed in the jejunum. Don't be confused if someone says that where the water is absorbed. Most of the water of the GIT is absorbed in the jejunum, but the remaining part of the water which will help in the solidification of the stool, that is absorbed in the colon. So the contents, the intestinal content that we see from the colon will be more solidified, and it will be more, the odor will be more feculent because there is more bacterial degradation. As you proceed from the ileum to the colon to the distal part of the rectum or the distal part of the colon, there will be more and more bacterial degradation. As a result, no doubt there is stool is solidified. It will also smell more feculent. That means the typical odor of the stool that we find, it will attain that odor. Unlike to that, in the ileum, the smell of the stool will be less feculent. So now how we differentiate ileostomy and colostomy? First, just by looking at the anatomical location where it is made. Secondly, the type of opening. One is the spigot configuration in the ileostomy. Third is the type of the effluent, the type of the fecal matter which is coming out from the opening. Okay, so this is the difference between ileostomy and the colostomy. And there is another type of ileostomy, is called the continent ileostomy, where we don't have, unlike the normal rectum and anus where there is internal sphincter and external sphincter. So we all know that the work of this sphincter is to store the the fecal matter temporarily for some period of time, until and unless we find a socially acceptable location or the place, or we go to public. Until unless we go to some toilet, we can contain our urge to defecate. So this kind of mechanism is brought about by the internal and external sphincter. But when you are creating a colostomy or ileostomy, such a wonderful mechanism is lost. So what will happen? What is the most common thing that we encounter is there is no control of the thing that is going to come out. So this is one of the things that colostomy and ileostomy patients, they are worried about, because you are speaking with the colostomy, you are speaking with someone, and sometimes just suddenly he will fart from the opening. It's not under his control. The stool matter will just come out like this with a sound, with a smell. So there is no control over this. So there is no sphincter, there is no control. But in some kind of ileostomy, we make a continent ileostomy. Continent means we can control to some extent. Now, how do we make this continent? We make the fold of the ileum. We fold it and make a pouch. This pouch will act as a temporary reservoir for the feculent matter. So the stool will be first stored there for some period of time. Before that time, the person will be aware of the sensation that my stool is getting deposited over the reservoir. I will have some fullness sensation. Then as soon as that sensation comes, he can go to a socially acceptable place, example in a toilet or a bathroom. Then he can do his normal thing. So then this is called continent ileostomy. So there is continent, just like we are creating a sphincter type of thing. So the advantage of this is that he can stay for some time without the ileostomy or the colostomy bag. In other cases, you have to put the colostomy or ileostomy bag 24/7 attached to the opening. But in a continent ileostomy, you can just free yourself for some time from the ileostomy or the colostomy bag. So So we have now learned that there are stoma. In GI stoma there are two types, mainly the colostomy and the ileostomy. And what are the different classifications of colostomy? Like there are decompression and there are diversion colostomy, temporary, permanent colostomy. Depending on the location, we have the first, the cicostomy, which is not exactly a colostomy, it's a cicostomy done in emergency conditions. Then we have the transverse colostomy, we have the descending colostomy, sigmoid colostomy, and the end colostomy. Then we have the types depending on how it is made. No, that it may be a end colostomy, or it may be a loop colostomy. It may be a double barrel colostomy, or it may be a spectacle colostomy. Then we have iliostomy, which is just like an ileostomy in its function, but different because of its different different part of the bowel which is used. That is the ileum, unlike colon. So the difference is that it is on the right side most of the time, not in hard and fast rule, but most of the time it's on the right side. It is comparatively more raised from the skin, and the configuration is called as pygot configuration. Then it is different from the colostomy because of the type of the effluent that is coming out from the ileostomy. It is more watery, it is more of electrolytes, more of bile, which is irritant to the skin. And such kind of patient who is having ileostomy, because lots of electrolytes are lost, so such kind of patient may have electrolyte imbalance. So we see patients having ileostomy coming back to the OPD, surgery OPD, and to the ward with electrolyte imbalance. So we have to take care of such kind of electrolyte imbalance mostly in a ileostomy. So then we have, depending on the effluent, that is the smell and color of the effluent, we can differentiate which one is ileostomy and which one is colostomy. So this is one thing. Now what about the closure of the colostomy or the ileostomy? Before you close the ileostomy or a colostomy, you have to make sure that the reason for which we have made this ileostomy or colostomy is no longer existing. For a permanent colostomy, there is no question of closing a colostomy, because it is there for permanent for up till the patient dies. But then if we are making a temporary colostomy, first we have to make sure that the initial reason for which the ileostomy or the colostomy was made is no longer existing. For example, if a person is having rectal cancer and you are making and is causing obstruction, and you are making a colostomy, proximal colostomy, like you are making a transverse colostomy or the sigmoid colostomy, then if you are planning to close this colostomy, then you have to make sure that the cancer part is dealt with. So if the cancer surgery is already done, then we can think of joining or closing the colostomy. Now if the colostomy is made for a reason, like suppose there is a perineal injury, where there is injury in the rectum or the anal canal, that is, it is severely lacerated because of road traffic accident and all, and we want to just divert the intestinal contents through a diversion colostomy, because we have to repair the perineum, we have to repair the colon or the lower part of the intestine, like the anus and the rectum. In that case also, first we have to make sure that the lower part of the rectum, intestine and the anal canal is properly made. Then we can think of closing the ileostomy or the colostomy. So first we have to make sure that the initial reason for which the ileostomy colostomy was made is no longer there, it has been dealt with prudently. Then lastly, since you are trying to communicate again the ileostomy or the colostomy, then the person is going to defecate through natural way. And then what will happen is, since the person have not been defecating with to the normal way, so his internal or external sphincter, that is with the anal canal, was not in use for so long, maybe 1 month, 2 months, 3 months, even 6 months, or even 1 year. So if he has not been using this sphincter control mechanism, if he has not been using it, then there is a tendency to lose it. So in our body there is the use and disuse. If you don't use it, you lose it. If you don't use your muscle, if you lie on the bed, you lose your muscle. Like that only, If you're not using your sphincter, if you're not using a sphincter to defecate, then normal anal canal sphincter to defecate, it will lose its ability. So what do you do? So what you do is you train your sphincter. So before you connect the two things, you first train your anal sphincter. How you do is you insert normal saline through a enema, or you insert normal saline around 500 ml like that. You insert and tell the patient to hold it with the anal sphincter. So if you can hold it, if you can hold the 500 ml of normal saline, you can hold it with your voluntarily with your sphincter. And you can, if you can able to defecate this normal saline in a socially acceptable place after holding it, then you assure that the person's sphincter is working properly. So if you don't do this physiotherapy type of thing, if you don't train the internal sphincter, what will happen is, if you're connecting the bowel, you thought that the initial pathology has been dealt with, and then you just connect, but you have not trained the internal sphincter. This internal sphincter is untrained and it will not function, and it will work as if the person is having diarrhea always, is not continent, it's as if he's having a colostomy. The colostomy that I made, it's occurring in the, normally from through anus also. So he has no control over the anal canal. So to avoid this catastrophe, we have to make sure that everything is normal like before, and even the internal sphincter also has been trained properly, so that you have a very favorable outcome. So this is in short about the stoma and GI stoma, the colostomy and the ileostomy, how it is done, how it is made, what are the types, how does it function, and what are the different types like ileostomy, colostomy, how we differentiate, how do you close the colostomy. So that's about stoma, ileostomy, colostomy, and we have discussed in brief. So I hope you have got a good revision. And let's discuss the next topic, that is the peripheral artery disease. Peripheral artery disease. Peripheral artery disease, from the name you can get an idea, that is, it is the peripheral artery. So we have the what are the peripheral arteries? The arteries in the leg and lower limb, upper limb, in the leg and hands. So these are the peripheral arteries. We are not talking about any abdominal aorta or something like bigger arteries, carotid or something like that. So we are talking about the peripheral artery disease. So the most common peripheral artery disease that we are dealing in surgery is the atherosclerosis and the thromboangiitis obliterans. But the most common is the atherosclerosis, but atherosclerosis again is dealt mostly by the medicine people, the physicians, but thromboangiitis obliterans, these are dealt by surgeon. So it is, apart from atherosclerosis and thromboangiitis obliterans, we have other peripheral artery disease like Kawasaki disease and post-radiation and other collagen vascular disease, resulting in peripheral vascular disease and sarcoidosis and all. So, but mainly we'll discuss about the PVD caused by the thromboangiitis obliterans. So, thromboangiitis obliterans is the segmental inflammation of the medium and small size peripheral arteries. Medium and small size peripheral arteries. Unlike the atherosclerosis mainly affects the large as well as middle and small arteries also they can affect. Large, medium and small arteries. But thromboangiitis obliterans, it affects mostly the medium and small size arteries, and it is the segmental inflammation. In segments, the artery is inflamed, and it is most commonly seen in younger age group, less than 40 years, and it is invariably associated with smokers. So when you take the history of thromboangiitis obliterans, mostly they used to show up in the OPD with complaints of pain in the leg, lower limb mostly, and with some show up with the complaints of gangrene and ulceration. So the complaints will be ulcer and gangrene and pain in the lower leg. So if you have to consider about the diagnosis of peripheral vascular disease due to thromboangiitis obliterans or de Burgess disease, then you have to ask the patient whether he's a smoker or not. So most of the time it is associated with smoking, and it is mostly seen in young male, not female, young male less than 40 years of age. So pathologically there is segmental vasculitis or segmental inflammation of the arteries, and there are multiple microthrombi. Pathologically speaking, there are multiple thrombi in the medium and small size arteries, and this thrombi has got small micro abscess. There are micro abscess in this multiple thrombi. And another classical thing about this thromboangiitis obliterans is that it affects not only the arteries, but it affects the veins and nerves also. So most of the time it involves the whole of the vein, artery and nerve. So you will see, because of the nerve is involved, the patient complains of pain, immense pain. So based on that, there is a term called intermittent claudication. So intermittent claudication is nothing but the degree or the severity of the pain, the classification, and this is classified under the Boyd's classification. If the person is having no pain, but on exertion, on doing exercise, the person is having pain, and it's called Boyd class 1. Then if the person is having pain, but after doing the physical exercise, the pain again it subsides, then is the second. Then the person continues with the pain. The pain is still there, but the person continues with the pain. Then in the last classification, the person cannot continue, but then we have the race pain. The person is not doing anything, but still the person is having pain. So this is called the race pain. So these are the different types of pain that a person encounters with the Burgess disease or peripheral vascular disease due to thromboangiitis obliterans. Then how will you diagnose this condition? To diagnose this condition, first from the history you will learn that he is a young age group male with less than 40 years with a history of smoking. Then the thing is, then next you do is a CT angiogram. You do CT angiogram of both hands and legs, because this is a disease of the small and medium sized artery, so it will affect the hand, it will affect the hand also. It is first seen in the lower limb, then it may be seen in the hand also. So there you will see that there is a segmental vasculitis, segmental narrowing of the arteries. Then you will see that there are multiple collaterals. The collaterals, suppose there is a block in the part of the artery, then there will be other bypass being made by the natural way. So these are called the collaterals. So you will see that there are collaterals being made, and there are small block which looks like as if it's a corkscrew appearance. This is typical, the appearance is called the corkscrew appearance. So we see that in the angiogram, we see that there is a corkscrew appearance of the small size arteries, peripheral arteries, and you see that there is a multiple collateral vessels coming out from different parts just to maintain the circulation. Then how can you differentiate what is the how critical the narrowing or how critical the narrowing is? Then there is a term called ankle brachial index. Okay, ankle brachial index. That's you measure the systolic blood pressure of the ankle and measure the systolic blood pressure of the brachial artery. Then you make a ratio of that, and in normal person it has to be 1 to 1.2. That means the systolic pressure of the ankle should be equal to the systolic pressure of the ankle. Ankle should be equal to the systolic pressure of the your hand. So if your ankle brachial index is less, it is less than 1, then we see that we know that there is a obstruction, definite obstruction, and if it is less than 0.4, we call it as critical limb ischemia or CLI. So like this we can differentiate how severe is the disease, how severe is the pain, how severe is the disease, and then with the CT angiogram you can see that where is exactly is the location of this pathology going on in the body, and then we'll try to manage this patient. Now to manage this patient, first is we ask the patient to stop smoking. Now the damage has been done by due to the nicotine contents and the other harmful metabolites that are there. This has caused this thromboangiitis obliterans. Now when you ask the patient to stop smoking, the cessation of the smoking will only cease the progression. It will not cure the disease, but it will cease the progression. First, it may be in the lower limb, middle size and small size arteries. It may, if he does not cease to smoke, then it will increase. It will affect other parts of the artery. But if you stop smoking, thus this progression will be curtailed there. So there will be no longer any. It will not be advanced, but it is not going to cure the disease. This is the initial one. So you ask the patient to stop smoking, then you can give some drugs like pentoxifylline. Pentoxifylline is a drug which causes the increase in elasticity of the flexibility and elasticity of the RBCs. So there is a narrowed blood vessels because of peripheral vascular disease. This pentoxifylline, what it will do is it will increase the elasticity of the RBCs so that it can squeeze itself through the narrow blood vessels. So somehow you can manage perfusion of that part of the limb by giving pentoxifylline, or it comes in the brand name of Trentel. Then you give cilastazol. Cilastazol is a very weak antiplatelet. We know that platelet cause clumping of cells. So if we give antiplatelet, though it is a very weak antiplatelet, it works in peripheral vascular disease by not allowing the cells to clump. So we have cilastazol, we have pentoxifylline, then we have to ask the patient to stop smoking. And if all these things are not working, if the patient is already developed raised pain, there is severe pain not allowing the person to sleep and all, then we can do some other procedure like lumbar sympathectomy, omentoplasty and all, or if the person is developing gangrene ulcer, then we can ask the patient to undergo amputation of that part of the limb, because it is a dying limb and nuisance limb. So we have what is the indications for amputation is that a dead, dying and dreaded limb. So if the limb is making a nuisance, if the limb is making life difficult for him, then it is an indication for amputation. This is how we manage the thromboangiitis obliterans or the peripheral vascular disease due to Buerger's disease. Okay, let's finish out here. Peripheral vascular disease and colostomy and ileostomy.
Thank you, sir.